Much of the information that we gather about a patient is going to be on a form. Patients will fill out forms, and then we'll talk with the patient after they fill out those forms about any questions we might have. We're going to go through a couple of those histories as we look at what there is as far as content in a patient's medical record. The first we're going to look at is the medical history. And in the medical history, we are going to document any history, any conditions that this patient has had in the past, whether it be any allergies that they've had, what medications they're taking or have taken, and what they've received for immunizations. The current medical history will include their chief complaint. What are they there for during this visit? And it will also allow us to document the history of their present illness, and then the physician will see them, and upon a review of systems, will document the medical history that's going on currently. Another history that's important to get into a patient's record is a surgical history. And all surgeries and procedures need to be documented and need to be part of the patient's medical record. Whatever surgeries they may be and the dates that they happened. And this will be important, for instance, if a patient comes in complaining of right lower quadrant pain, and a physician sees in their surgical history that they had their appendix removed 10 years ago, they're not going to order any diagnostic tests to see if the appendix is healthy. Family history is an important part of a patient's medical record. It allows a physician to see whether or not a patient is predisposed to any conditions. A lot of times certain cancers will run in families, and if we know that the patient has some history in their family, then that may be a way for a physician to assess what's going on. Social history is going to give the physician information about smoking or drug use, or whether or not a patient is involved in any activities that could put them at greater risk. All of this history is part of the medical record, and then when we are filling out the current medical history, we're going to do it on a form, an encounter form, in a SOAP note. And SOAP literally stands for Subjective, Objective, Assessment, and Plan. And let's look a little bit at what subjective findings might be. Subjective findings are those things that we can't necessarily see or measure, and it's normally what a patient explains to us is going on. It is how they feel. Pain is subjective, and those things need to be documented under the S part of the medical record. Objective findings are those things that we can measure, that we can see. We can talk about a patient's blood pressure as part of the objective findings in a medical history. We can put in there height and weight. Those are objective findings. Those are the parts that the medical assistant will fill out. The assessment is done by the physician during the review of systems or the exam, and the plan will be written up based on what this physician finds in their assessment. So again, it's going to include our history of present illness, that is, what is the patient feels going on and what they have to give us for information. Our objective findings will fit in there. Then the review of systems by the physician, and a physical exam if that is warranted. Following the visit, there will be some, in most cases, there will be some diagnostic tests ordered, and if the patient needs a prescription, we will be following e-prescribing, which is the way that we do this electronically. They're sent to the patient's pharmacy from the point of care. And the best thing about e-prescriptions is not just that it speeds up the process, compared to a written prescription. It also is going to help to improve the quality of care. All the information about the patient is going to go with the prescription. So the pharmacist is going to have all the information about their demographics, their insurance, their allergies, any medication history that they have. And so it really will help the pharmacy to avoid any medication errors. They will have information in there about certain medications that shouldn't be taken together. And the dosing errors are going to be avoided better than if it is a written prescription. And it's very efficient when the physician wants to renew a prescription for a patient. Part of the plan that's written on the soap note will have on it certain treatments or tests that need to be performed. And it's just important to remember that none of this will be done. There'll be no treatments, there'll be no tests, there'll be no medications given without a care provider writing it down as physician orders. It has to be documented on the medical record. The electronic health record really gives an efficient way to track these orders, and then when the results come in from any of those tests, they can be put right in the electronic record, and the results are very easily found and tracked. Also included in this medical record is going to be a problem list. And what a problem list is really is just current and active diagnoses that are kept in an up-to-date list. And it is one of the requirements to prove meaningful use going forward. It provides quality care to patients. There are diagnoses and conditions that are followed up until the problem is resolved or stable. So there aren't any conditions that the patient comes in with that we aren't tracking until we get to the point where we've stabilized their condition or whatever it may be has been resolved. The electronic health record really helps a practice with their financial management, because although a medical office is in the business to provide patient care, it is a business, and it needs to be able to make money, to stay open, and to administer any sort of patient care. So use of practice management software is going to improve that efficiency. So the medical record is all that happens clinically and the histories and all of that. And the practice management software is going to help us to take care of the administrative side of an electronic health record. Again, we've mentioned this before, verification of insurance information when making the appointment and then again at check-in is essential for that practice to effectively submit claims. If we don't have all the information that we need, if we don't fill out those claims forms completely and accurately, payment will be denied, and then that now takes longer and more time and for us to receive payment for the practice. The super bill or an encounter form will have all the information that we're going to need to use to transfer over to the CMS 1500 claim form. When a patient is done with the practitioner, they will come out with an encounter form or a super bill, and we will be able to take the information off of that to turn into the insurance company to make a claim. The name and the address of the medical practice is going to be on the claim form. The patient's name and charge number will be on there. The date and time of the visit. The CPT or procedural code will be on there. That will list what actually happened that day, what procedures were done. And then the diagnosis narrative will be there in the form of an ICD-9 code. And the ICD-9 code is the reason that we performed a certain procedure. So every CPT code needs to be backed up by a diagnosis. Here we have a visual of what an encounter form might look like. If you look on the left-hand side, it talks about established patient services, and it tells in there by that code what type of exam it was, how long it took, and the differences will make a difference in how much we charge. There should always be a diagnosis. If you look down at the bottom, it lists several diagnoses that could be used. On this one, it says under signs and symptoms that they had abdominal pain, and that is the ICD-9 code for abdominal pain. The diagnosis needs to fit the procedural code. Copayment that a patient may have, according to what type of insurance they may be carrying, could be collected at the time of check-in or check-out, depending on the office policy. Every office will have a different policy, and you'll just have to get to know what it is at the practice where you'll be working. Charges will start to accrue when the patient is taken to the exam room and is seen by a healthcare professional. So as soon as a patient enters the exam room and the healthcare provider starts their visit with that patient, charges then start to accrue. Coding, ICD-9 and CPT coding are done for statistical purposes as well as reimbursement purposes. So ICD-9 or diagnostic codes are in place so that we can track the likelihood of diseases in certain areas, how often a disease has been diagnosed, and so forth and so on. These codes are definitely required in order for us to get reimbursement, and these ICD-9 codes will soon be changing to ICD-10 codes. Services could be anything from the office visit to diagnostic testing. X-rays have a procedural code. Lab tests have a procedural code. They may be therapeutic. So if sutures administered, if there's an injection given, those also have CPT or procedural codes. All services and procedures performed must be medically necessary in order to receive reimbursement. Again, any procedure or CPT code that is written down needs to make sure that there is a diagnostic code that makes it necessary to perform that procedure. All diagnoses have to support that the medical necessity. Otherwise, insurance companies will not reimburse. So services that are performed that are not deemed medically necessary and billing for them, and you bill for them anyway, is considered fraud